It's been a very interesting perspective for someone as myself who's practicing medicine, to read about things from a very different vantage point, and it's been illuminating. So I hope that the questions that I've prepared for us to write about will also, again, interact with how you all as practitioners also see the world. So in Mangusa's book, which I believe all of you have either read or skimmed in the past, she writes about so many different types of providers that she encounters: neurologists, physical therapists, nurses, etc. And she has many different recollections, as she writes about in her book, about these various types of providers. So what I wanted to do is have you write about not her interpretation of what makes a good provider versus a bad one. She doesn't come out with those words in her stories, but definitely the connotation is there. And then expand upon that and say, what characteristics do you all think make a, quote, good provider versus a bad provider? And then I would like to flip that coin around, which is to ask ourselves, do you think Manguso is a good patient? And if she were your patient, how would you interpret her? As, an ideal, good, bad, or where in the spectrum? And what qualities might that she's shown in this book would surface? So I will give us, say, 15 minutes to sort of put our thoughts down on paper, and then we can take it from there.
Yeah, so I have an example from last week. I was screening a new patient, a family friend who had contacted me about wanting to come in. And so I was going through everything, usual process, their health history and everything. And then my instructor comes over, and her eventual treatment plan is to get teeth extracted and a denture. But so I presented to the instructor, he came over and he was like, she looks pretty miserable. Like, we should probably try to get a tooth pulled today. And I didn't pick up on that. I didn't think that was something that we would be doing that day. She had expressed some nervousness, and so I think I was interpreting her body language as being nervous, not pain. And I never asked her, even though one of our first questions usually with the patient is, are you experiencing any pain today? Because we want to obviously get them out of pain. And I think because she hadn't expressed that to me earlier, I didn't think, oh, she's in pain right now. And so we were able to get the tooth that was bothering her out that day. And I think she was happy that we could take care of that tooth complaint, even though I didn't pick up on it initially.
Well, interesting, because anxiety is a form of suffering, sometimes not obviously or not stated by the patient in those terms, but it can cause as much grief as, say, physical type of pain, like a toothache, right? That's what you're saying.
Yes. But yeah.
Slightly different perspective. So I kind of focus on my non-clinical responsibility. So often, I'll just read that. So often all I see of a patient is a piece of tissue taken from their body on a glass slide. It's easy to ignore the suffering in this role, but I try to remember always that there is a patient affected by my diagnosis, either in a good or bad way. Sometimes they want to rule out cancer, and it's not. And so I try to kind of remember that. That's good news for them. It's always humbling when faced with a difficult or quote, painful diagnosis in the sense of it's a cancer in a young patient, for example. And similarly, my husband is a radiologist, and when he feels that same sense of kind of detachment that you're looking at radiographs all day, but he doesn't really see the human that's associated or linked to that image, I'll ask him, how were your patients today?
That is a very, very important connection, right? To always remember, keep that in the forefront, because That's all the hard work and training, everything you've done is for that ultimate alleviation of a person's suffering. Anyone else would like to add to their interpretations or manifestations of suffering that they see?
I was going to say that suffering is not always physical, it can be psychological. So anxiety was one of them, but also guilt. Maybe they're in financial trouble. Maybe unfortunately terminally ill or really ill patients. It's kind of lost, and they have to be taken care of by a whole bunch of people. They don't have privacy. They don't have sort of, the basic dignity of being able to do stuff for themselves. So there are all these psychological aspects to it. So I think it's important to keep those things in mind as well.
So there's a multi-dimensional approach to when you look at suffering.
Sure.
And Manguso points that out, for example, in the chapter which she's talking about the nurse who was a cheerleader at her high school pep rally that she encounters, and she's got to wipe her butt because she's just paralyzed, and that is the kind of suffering, that she points out to us. It's a loss of her dignity, and all of that is swept away. And there can be other types, like you just have mentioned, economic hardships that sometimes are visible when a patient comes to you, and sometimes you don't know, might be manifest in other ways. And also there are other types of psychological things that happen. For example, if you have widowers, I have so many widows and widowers that come around the holidays and they're just depressed. I mean, I'm seeing them for a heart issue, but just to get through the holidays because they're not alone is a kind of suffering. Or ruminating over not only that I'm having the pain now, but what does this mean for a future down the road? That also brings a type of mental suffering that you have to be cognizant of, I think, to best help the patient.
I had a practitioner friend who, he practiced in a rural area, and a lot of his patients were elderly, and they just came there to talk to him. Really, they didn't have much wrong with them. So the fact that he just sat down and talked to them was a big deal.
It was good medicine.
Yes.
Yeah, and it is good medicine to do that. And it's always something that we have to keep in the forefront, especially as you're seeing patients. And, even when you're having a bad day or something, to remember that is the ultimate purpose of why you're in this. Any other thoughts to?
For this, I put suffering. I mean, what I see mostly is like regret. I could have done this. This happened to me. I could have done that. I regret that I didn't do this, so it led up to this. I mean, but with my patients, I try to communicate that at least we know now. At least we can put into words what's going on.
Are people coming with late diagnoses? Is that?
It depends, patient. But I mean, yeah, a handful.
Yeah, it's interesting. Sometimes if people are at end of life, what the regrets most often are, I didn't spend enough time with my family. Not necessarily I didn't achieve, I didn't get that MBA or whatever degree I was after post, but the communication between, or the interpersonal relationships.
Yeah. I'm actually currently reading a book on vulnerability. I totally forgot the title. But anyways, it's just, that level of vulnerability that your patient puts themselves in. And, people are vulnerable in different situations, and you think to yourself, man, I can't do that. Maybe I'll look weak, or maybe this and that. But whenever you see someone being vulnerable, you're you kind of proud of them. That's awesome. But when you reflect on yourself, you're like, I don't want to be vulnerable. And so, I think the best way to communicate with your patients and to really just listen to them is just also at some level, maybe not at their level if you're not comfortable being at that level, but being somewhat vulnerable. And that's what I try to do with my patients. Yeah.
That's a very big part of the human connection, to feel that, they're suffering, you can understand, you're trying to empathize, and you also are trying to understand how hard it might be for them to even come to you with whatever issue it was at hand. And, sometimes patients might even ask, have you had a similar, have you ever been through something like this? And sometimes they want to know because it brings you on equal footing, if it's that connection. My husband had heart surgery, so now when we literally just 6 weeks after we got married, so whenever I go and take someone into surgery, I'll always tell them about, I've been on both sides of the equation here, as a physician, but also as a wife, waiting, and I know how horrible, exactly how impossibly horrible those moments of waiting are because of the uncertainty of not knowing. So I think that is very, sometimes doctors, providers will allow the vulnerability to show through.
I mean, not even like personal experiences, like even saying that, hey, I'm not a specialist in this and I can't treat this because I'm not up to par. Like, to me, that's like being vulnerable, like letting them know that you don't think you're competent enough to do this. And I think patients really appreciate that, not because you're admitting it, but more or less that you're vulnerable enough and to put it out there.
Right. That you're acknowledging and you're being truthful.
Yeah.
That's definitely essential. Well, thank you so much for coming today and